Thank you, everybody, for joining our COVID-19 lecture series. Tonight, we're going to be hearing from Dr. Schlesinger from Vanderbilt University Medical Center and Dr. Hurst from Montefiore New Rochelle Hospital. We are offering these sessions tonight in Khmer and Vietnamese. And so if you are interested in hearing it in Khmer, please choose the Chinese option on the interpretation button at the bottom of your screen. And if you are interested in hearing it in Vietnamese, please choose the Spanish option. We would like to apologize for having to use Chinese and Spanish for those languages, but Zoom does not offer those as our choices. I would like to now pass it over to my colleague Vaughn, and she is going to go over a little bit about Zoom etiquette.
Hi, everyone. I'd just like to touch on a few etiquette points. We'd like to remind you that ECHO is a platform built on kindness and respect, and we rely on you guys to keep this a collegial space for learning. If you have any questions, you can write them in the chat box at the bottom right hand of the screen throughout the lecture, and we can address them then again at the end at the Q&A session, or you can use the raise your hand function under the participants toolbar to ask a question. At that time, the moderator will call on you. Please mute your microphone when you're not speaking. And should you have any questions, IT problems, feel free to ask in the chat box or send an email. Now I would like to introduce our speaker, Dr. Schlesinger.
Before we do that real fast, I'm sorry. Boon Yang, could you please start recording the Khmer session, please? Thank you. Sorry, Dr. Schlesinger.
It was great to meet everyone, and I'm here presenting with my colleague, Dr. Hurst. As was introduced, I'm at Vanderbilt University Medical Center in Nashville, Tennessee. I'm an anesthesiologist and ICU physician, and Dr. Hurst is an internal medicine doctor. And of note, her hospital's the epicenter for the initial COVID cases in New York, and we'll talk about the care pathways that they've been using. The important thing to note tonight is a lot of this, since it is a novel virus in the way we approach care, there's ways that we approach things based on evidence, but we've also had to be creative and think outside the box when we think of taking care of patients that have unique disease presentations. So tonight, the learning objectives, as you see, we'll talk about acute respiratory distress syndrome because that's the constellation of presentation that these patients typically have from a pulmonary standpoint, so the associated risk factors. And then we'll get into the COVID care essentials, realizing that not everyone may be able to do these things at their hospital, but talking about things you can think about. And we have some videos as well to show some of these techniques. You'll also get these slides so you can refer back to them. With this comes prone positioning, which is laborious and requires a lot of nursing care, and then some new anticoagulation protocols which have been developed at Dr. Hurst's hospital. So we can go to the next slide. And this table has a lot of text. Again, you'll have these to refer to. The main thing to think about with the acute respiratory distress syndromes, the Berlin definition, was really changed from the previous definition, which used pulmonary artery catheters, which are very invasive and have a lot of risk associated with them. Besides the timing and imaging, this really breaks it down into the PF ratios, or the PaO2 over FiO2 ratios on arterial blood gases. Now, I realize not all sites have the ability to do arterial blood gases. If you do, you can see the mild, moderate, and severe are broken down into those ranges. A lot of this is going to also be clinical presentation. So when you see these patients struggling with oxygenation, if you have chest imaging, you can see the bilateral opacities, which we'll have an example on an upcoming slide. So if you have the ability to do arterial blood gases, this is a way to help grade it. However, the clinical presentation is going to take precedence most of the time. So if we go to the next slide. Here's a classic picture of ARDS. You can see the bilateral kind of fluffy infiltrates. There's the different stages, the initial exudative stage, the proliferative stage. One thing that we're going to learn throughout COVID is really the chronic problems that persist. With ARDS, when patients survive their hospitalization, typically they do okay long term. There's obviously some chronic morbidity and mortality. What we're going to need to learn, though, with COVID is how the lung parenchyma is going to be affected. If there's going to be chronic fibrosis and issues that are going to have with long-term oxygenation or home oxygen therapy. And really that's going to do a lot with the pre-hospital comorbidities that we're going to talk about with the ARDS comorbidities, but typical things you think about like morbid obesity, hypertension, coronary artery disease, smoking, and things like that. So again, since it's a novel disease presentation, we're still learning about what's going on in the acute phase, but then especially the chronic phase. Speaking of the chronic phase, the difficulty too, as we've had in the United States, is when patients are coming from nursing facilities or long-term acute care facilities, we get them through that acute phase, but then a lot of times these facilities don't want them back, because even though they get through the initial 2+ week hospitalization, the resultant infection or reinfection rate or communicability of COVID is still not understood. So we're struggling from a hospital standpoint, especially from a resource standpoint. So as you all have seen on TV when it comes to ventilators and masks, that's part of it, but also patient throughput and where they go post-hospitalization. So we can go to the next slide. So these are risk factors for ARDS. You can see some of them are highlighted, or bold rather. And so obviously having sepsis, infection, and pulmonary embolism we're going to touch on later, because there's also a vascular component to COVID where there's a hypercoagulability. And at the very end, we're going to talk about the novel approach that Dr. Hurst helped develop at her hospital on anticoagulation for these patients and how to monitor and think about being very aggressive and not waiting for them to present in a hypercoagulable fashion. While we're talking about COVID and ARDS, other things to think about is not every patient that comes in short of breath with a fever has COVID. Of course, that's going to now leap to the top of our differential. But of course, you need to think about other things that are on this list and any other typical comorbidities or disease presentations that could happen. But when we think of the constellation of symptoms with COVID, there's also some interesting things that we've seen that haven't typically presented in a typical pneumonia or COPD exacerbation. We've started to see GI symptoms such as nausea and vomiting, which can be really intractable and almost not responding to Zofran or low-dose Haldol or propofol, diarrhea, and so we're struggling with nutrition and fluid balance. Also, alterations of taste and smell, which is probably mediated by the olfactory nerve, which then we have a taste impact. And then a rash, which can be subtle, typically seen on the extremities, more hands than feet, and slight maculopapular presentation. So let's go to the next slide. So the clinical presentation, which you all have seen before, I'm sure, is besides the dyspnea and tachypnea, is oxygenation. The interesting thing about the hypoxemia here versus the typical ARDS patient is we've seen a lot of patients who have had hypoxemia who are still maintaining their mental status, where it almost seems like you're not trusting your pulse oximetry. So when we think about oxygenation and ventilation, that's where if you have the ability to check an arterial blood gas or at least end-tidal CO2 to get a sense of the ventilation. But we think about the increase in shunt fraction and increase in dead space ventilation. So as a reminder, just from a pulmonary physiology standpoint, when we think of shunt, of course, we have ventilation. We have poor ventilation with perfusion, and dead space is the converse of that, where you have ventilation with poor perfusion. So you're struggling from oxygenation, but a little less so with ventilation as you would see in ARDS. And that's why the mental status in these patients may be maintained, because they are not getting as floridly hypercarbic as they might otherwise in an ARDS presentation. So you see hypoxemia, and the typical reaction, of course, is to intubate. But we're going to talk about this algorithmic approach that we've developed to think about the hypoxemia and how to manage things, not only from a patient care standpoint, but from a resource utilization standpoint. So let's go to the next slide, please. So this is a busy slide, and we've also had some variation on how we approach these. This was developed as a care pathway at Montefiore, and they've really been leading the medical practice at that hospital and in New York, as they've seen just the sheer volume of cases and from a chronologic standpoint in the United States. Some things have fallen a little bit out of favor. The procalcitonin has fallen a bit out of favor when you think of using antibiotics or looking at the inflammatory response. The D-dimer is very interesting. We're going to talk about that later in the coagulation section coming up. But interestingly, we've had things like the C-reactive protein and other non-specific inflammatory markers that have been generally good to trend to look at the synthesis of the clinical presentation. You can see the bold point, and this is a really important thing as we think about the morbidity and mortality. Once intubated, we've seen high mortality, and of course it's kind of a chicken and egg issue, and it's not causation and correlation, but it's really talking about code status early, and it's talking to the patient, their healthcare proxy, the next of kin who's making decisions on what the patient wants and how the care pathway is going to happen. Because once you get into a point where the patient's in the hospital, a lot of hospital systems, including Vanderbilt, including Montefiore, have now disallowed visitors. So if you don't have a visitor at the bedside, you are required to try to contact family, but it might be very difficult. You may not have a working phone number, or you can't find them on WhatsApp or whatever it is. And so you don't know what the patient wants, and you don't establish that early. You're put in a very difficult ethical dilemma, especially when you start looking at the shortage of supplies. If you're running into issues where you don't have enough ventilators, or your ICU is full and you have critically ill patients on the floor and you haven't had this code status discussion early. So we can't emphasize that enough, that as difficult as this conversation is, it's extremely important to have early on. Let's go to the next slide, please. So here we, as I said, we're not trending procalcitonin, so we added this in to make that clear. It's kind of a smorgasbord of labs, and you can see the issue there is obviously repeated blood draws. You may not have access to get blood this frequently. You may not have access to a lab that can run all these labs, and you may not have a nurse that can do vital signs as much as you want. And so we get into this difficult position where it's easy for me to say, well, this is what you should do. Even we can't always keep up with our own recommendations. So we try our best practice, but you know, it's difficult to get the labs daily, get the morning labs actually done in the morning. So when you round on the patient in the morning, you have the labs that you can address, that you're not looking at labs that are 24 hours old or 36 hours old. The DVT prophylaxis, we're gonna again touch on later. And then there is the data that NSAIDs have the risk for AKI. And so there's thought about using Tylenol. And I don't know in your respective countries, but if you go to a store in the US, we're pretty much out of acetaminophen or paracetamol, depending on what you call it in your country. Let's go to the next slide. So this is the algorithm that was developed at Montefiore, where we start thinking about supplemental oxygen, where we start with nasal cannula, obviously titrating up. And once you get to 6 liters per minute, that's when the transition is made to VentiMask. And again, this isn't a JAMA paper. This isn't a 10,000 patient randomized controlled trial. This is taking a novel virus, novel patient presentations, and what we need to do. And we're really at the front lines, and we say that is, Dr. Hurst is really in the trenches fighting a war. And so you have to think about, when are you going to make these care transitions? And you're going to make them by this algorithm, is what we've practiced. So this is not to say at your hospital, if you feel the right change is at 4 liters or 8 liters per minute, that's fine. This is not ingrained in stone. It's for you to take what we're saying we're doing, seems to work generally, but you need to adapt it to your practice setting. So once we hit 6 liters per minute, we're struggling with oxygenation. We'll switch to a VentiMask. Struggling with that, 100% non-rebreather. When we struggle there, we've done some unique things, and you can argue about the utility of this or how this might work. But when we've struggled there, we've added nasal cannula back with the non-rebreather. You could say, well, is that really effective? Are you losing your seal with the non-rebreather? It was a way to try to potentially kick the can down the road a little bit to see if we do get any benefit of dissolved oxygen or if we can improve oxygenation. But then we have talked about proning patients. And my feeling in general, when you look at any published literature on ARDS, is we typically prone too late. It's effortful to prone, so we don't want to do it. We're in denial. And we've typically proned intubated patients in the past. And this is really the unique care pathway that we've developed that is proning patients before they're intubated. So when you think of an intubated patient, it's effortful to prone because they're sedated, they're intubated, you're not going to want the tube to come out, obviously, and they're pretty much dead weight. They're not going to be participating that much in the proning process because they're sedated, because they're intubated. So if you have a patient with supplemental oxygen, the non-rebreather plus the 8 liters per minute of nasal cannula, if you can prone them and they can assist in moving them, it's going to help you out. Of course, this is a practice paradigm difference. Obviously, in America, our patients tend to have a larger body habitus. Let's go to the next slide. So this is a continuation of the previous algorithm. We left off from the non-rebreather plus 8 liters per minute prone. If you're struggling there, go to high flow nasal cannula, they're prone. And then we have a decision to make here. So BiPAP, if they do not intubate, obviously that's their wish, you're not going to intubate. But we've also been forced to do BiPAP in patients who arguably should be intubated, depending on where they are in the hospital. So at Vanderbilt, we can't have patients intubated on mechanical ventilation, not in an ICU. We've increased our ICU capacity by turning step-down units into ICUs. But if you have a patient on the floor and you don't have a respiratory therapist and you don't have a ventilator and you don't have a way to manage an intubated patient, you might have to have patients on BiPAP longer than they need to be, even if there's an indication for intubation. If you do intubate, obviously, depending on the respiratory mechanics and the pulmonary compliance, you then make a decision on a volume mode or a pressure mode of ventilation, keeping in mind of the 60 per kilo ideal body weight, which is based on the ARDANET trial, which interestingly was done at Vanderbilt. And to maintain oxygenation, you may need escalating PEEP. The thing to keep in mind, of course, is if you can, to keep the plateau pressure less than 35, but you have to, keep the patient alive, look at oxygenation, look at ventilation, and then think about where they are in the hospital. Are the respiratory therapists, are the people who know how to manage the ventilator? What we've started to do ahead of time, as our surge here at Vanderbilt has not hit near the volume that Dr. Hurst has had to deal with, is we've started to train non-anesthesia physicians and non-ICU physicians on basics of mechanical ventilation. So depending where you are with your own patient volume, you might want to think about doing that now. Is taking care providers who aren't typically used to managing mechanical ventilation and train them now on simple ideas of what does it mean to be in a control mode versus assist mode, spontaneous mode, what is pressure, what is volume, what is oxygenation, what is ventilation. So at least you have some skill in other providers that can communicate and make some changes, which could help the morbidity and mortality of these patients. Let's go to the next slide. So this is a rotaprone bed. We can get some of these. This is an extremely large bed, which takes up most of the ICU room, and in fact has to go at a 45-degree angle to fit in the room. The whole reason we're talking about proning patients without using this bed is because we don't even have enough of these. It's from a company and we rent them, and a lot of hospital systems don't even have access to it. But this is to show you in a non-COVID world, when we have ARDS and you think of down the line ways we address oxygenation and why we prone patients, you put the patient in this bed supine, you strap them in with all the seat belts, fasteners that you see, and then the bed can rotate them prone and supine. As you can imagine though, when you have them intubated and have the lines, that it's easy for things to come out. The last thing you want is this patient to be in this bed, fastened up, prone, and then they self-extubate. So that would pretty much lead to certain death. So this is not something that we're doing regularly. This is just to demonstrate what we've done in ARDS. If we go to the next slide, you will have the slide sets. So this YouTube link is relatively long. It's, I think, about 17 minutes. So watch that at another time, but please do watch it. New York is really, I think, leading the nation, if not the world, on COVID practice. And this comes from Mount Sinai, one of the other hospital systems in New York, where they talk about manually proning patients. So that is without using the rotaprone bed. And you can watch the step-by-step approach where they take the patient with bed sheets and then they prone them. So this next slide, when you have that prone patient, we're going to watch this. It's a couple minutes, but let me just set it up. As you think of patients when they are prone, well, if you have to do ACLS and chest compressions, what do you do? And that's not something we're taught right now by the American Heart Association or the other international regulatory bodies of ACLS. So let's watch this video.
There have been several case reports of successful intraoperative CPR for patients in the prone position, and some studies have shown that it is efficient from a hemodynamic point of view. We believe that there will be a significant delay in commencing CPR if the intraoperative patient is repositioned into the supine position prior to starting chest compressions. The aim of this video is to introduce the concept of cardiopulmonary resuscitation in the prone position and techniques on how to perform it. There are no guidelines on cardiopulmonary resuscitation for patients in the prone position, but the American Heart Association recommends CPR in the prone position is a reasonable alternative for intubated, hospitalized patients who cannot be placed in the supine position. If cardiac arrest is diagnosed, the standard ALS algorithm should be adhered to. In these patients, it is likely that they will be intubated, or if not, have a well-fitting LMA in situ. In this event, continuous chest compressions should occur with a ventilation rate of 12 breaths per minute. With regard to chest compressions, a sternal support must be placed to provide sternal counterpressure and protection on bony prominences. This can include the use of sandbags or bags of fluid which can be slipped underneath the sternum. Chest compressions may be performed using one of two techniques. The first uses both hands over the mid-thoracic spine, remembering that the surface landmark for T7 is the inferior border of the scapula, shown here by palpation. Chest compression should be carried out at a ratio of 100 to 120 per minute. The other technique uses one hand either side of the mid-thoracic spine, using the landmarks as before. Defibrillation pads can be positioned most easily in the posterior apical position, but they can be used in the anterior-posterior position also. Out of the two positions, the anterior-posterior position may provide a greater transmyocardial current, but does require the patient to be rolled to one side to place the anterior defibrillation pad. We hope this video was useful and provides a tool to at least initiate CPR in the intraoperative prone patient who is in cardiac arrest.
So you can see important things to think about if obviously your prone patient does need ACLS. The other care pathways that have been developed at Montefiore are steroid pathways. So you can see the clinical indicators there. It's really when you're struggling with oxygenation or if you have this rapid rise in the C-reactive protein. Let's go to the next slide. And then if you do meet those clinical indicators, this is the way they've approached the weight-based steroid, which is a little bit different than the pure stress dose steroids, 4 or 5 days, and then tapering thereafter. Still looking at oxygen requirement and the biomarker response, again, here being CRP. Point 3 has changed recently over time, where at the outset, before some of the work on hydroxychloroquine had come out, we were using it, and then this has now fallen out of favor with it falling off of our protocol just in the past few days. So point 3 could be disregarded. The reason we kept it on the slide was just to show that we did do it historically, and to make the point again is when you're dealing with a novel disease presentation, we were aggressive thinking about, well, what can we do, especially with the high mortality that we've seen in New York. So next slide. If you're still struggling with oxygenation and you have the patient who's intubated and they're prone and you've done all those things, kind of the end of the road thing to think about is neuromuscular blocking agents or paralytics. We've used these in severe cases up to 45–50% of the time. If you do this, there's some mixed approach based on the background and training. It's the medical intensivists tend not to use train of 4 monitoring as much. I think it's a good idea. It's not just my thought as an anesthesiologist. This is the way we monitor the depth of paralysis in the operating room or operating theater. It's important to note you do not need the absence of twitches. 1 twitch out of 4, you still have about 90% of your receptors blocked. So titrate where you don't need extreme depth of paralysis. So use your train of 4. Sedation is paramount. Obviously, if you have a patient who is paralyzed, you do not want awareness. So when we talk about sedation, we've also seen increased issues of ICU delirium in these patients with COVID. So when you think about sedation and you target a RAS goal that will ensure amnesia, really try to avoid benzodiazepines. Obviously, benzodiazepines have an increased incidence of ICU delirium, as you can read about in work by Wes Ely and Pratik Pandey. But even here, especially that we've seen increased type of hyperactive delirium with COVID positive patients. So be very careful about the selection of the pharmacotherapy for the sedation. And then there has been, I included the reference for you to click on when you have these slides to read about the dosing and reduction of mortality and the benefit of using neuromuscular blocking agents. So let's continue. And then we're going to wrap up here with the anticoagulation. We've seen a vascular phenomenon with COVID where there's a hypercoagulable state. And so remember, as I said at the beginning, not every patient who's short of breath and hypoxemic has COVID. Not every patient who has clots is because of COVID. Think about other issues or other causes of bleeding. If you're thinking about thrombocytopenia or thrombocythemia, liver disease, anemia, make sure you rule out other common things being common. And when we have novel disease presentations, we always tend to think about these rare causes. But that said, we have seen these hypercoagulable issues with COVID. And so let's go to the next slide. And this is the algorithm that's, again, been developed at Montefiore, where this is a continuation from the previous slide in the box, and then assessing patient stability. Realizing you may not have a thrombosis or hematology consult team at your disposal, but if you do, consider an early consultation. If the patient's stable, this is the one time where we found that D-dimer is actually beneficial. And it's interesting as we look at probably everyone's medical education when you've learned about D-dimer and pulmonary embolism or other hypercoagulable states where it's very nonspecific. And but here it's been shown that to trend it and look at the value has helped in a bifurcated decision-making model on the dose of either thromboprophylaxis or therapeutic anticoagulation. At Montefiore, they've been using apixaban. You can see the difference between the dosing of the thromboprophylaxis of the 2.5 BID versus the therapeutic anticoagulation of 5 milligrams BID. Going to the next slide. I'm sorry, let's go back. So some centers are using low molecular weight heparin. I forgot that was actually at the top of this slide. I thought it was on the next one, so I apologize. If you don't have apixaban, you can think of obviously whatever you're used to using, be it heparin, Lovenox, low molecular weight heparin. Again, this is a novel presentation. So I realized that apixaban is a newer drug in the US, and I know the availability is not necessarily worldwide. But the important thing here that we want to impress upon you is that think early about these hypercoagulable states, think about early prophylaxis, think about being aggressive with it. Of course, you want to make sure that there's a risk of bleeding if you swing too far to the other extreme, and it's the constant bleeding, clotting balance. So, but the last thing you want to do is be slow and drag your heels, and then the patient has horrible pulmonary embolism and then dies of that. So finally wrapping up, which you can ask more in the answers, in the questions and answer section. This is Dr. Hurst Hospital in Montefiore in New York, in New Rochelle, which is just north of Manhattan. And I wanted to point your attention to the white trucks in the front. And those are refrigerated trucks that there's been such high mortality of COVID, especially working at the epicenter of COVID, is these are used as makeshift morgues. So those are refrigerated trucks filled with dead bodies. And part of this too, besides, we were talking about the medical practice of it, and that's important, but we need to think about self-care and the psychological and emotional impact of taking care of these patients. And it's something I think we don't talk about enough. is imagine going to work and looking out the windows of your hospital and seeing the white truck. And if you can see towards the left of the picture, it's harder to appreciate, but at the base of the white truck, you see a wooden structure. That's a ramp. So the staff can wheel the bodies up that wooden ramp into the truck. And to have to look out the windows and see that every single day is a very scary reminder about the seriousness of this disease and how we need to think about taking care of ourselves and taking care of each other. And that, you know, we're truly fighting a war here, and this is a novel thing. And so we need to think creatively, of course, evidence-based practice, but realizing you're doing the best you can do with the information that we have. So thank you for listening, and we're happy to answer questions, realizing that we may not have all the answers to your questions.
Thank you, Dr. Schlesinger. That was really great and very informative.
Thank you.
Dr. Hurst, would you like to share just briefly maybe about your experience being in one of the hot spots before we open it up for questions?
Sure. So I'm a resident in internal medicine at the Montefiore New Rochelle Hospital, which is a very small community hospital. Typically, we're about 150 to 200 bed hospital. And over these last few weeks, we've had to increase our capacity to 150%. So there's been a huge influx of new patients. Everyone has been working with a far heavier workload than what we're used to. So the challenge is not just in terms of the numbers, but in terms of the emotional toll that it's taking on everyone. Despite all these new protocols that Dr. Schlesinger has described, unfortunately many patients end up suffering a lot, and unfortunately many of them end up dying, as you can see from the truck in the picture showing the trucks. And even before, when patients initially present, it's an emotional struggle from the beginnings. And as was mentioned earlier, the code status, the goals of care is a big thing. COVID-19 affects many young patients too. So patients who haven't previously had to think about this, they haven't had to think about goals of care, what they would want at the end of life, if they want to be intubated or not. And people are aware of the numbers, they watch the news. And so for me, I've dealt with many patients who are just terrified of what's going to happen to them, about death ultimately. And it's hard for us as healthcare providers to talk with these patients because we know we can see the progression of case after case. People do very poorly, and patients are aware of that too. And so it's very hard to have these conversations with people. That's an ongoing challenge that we have. There's also, from the perspective of the healthcare workers, many people are working outside their normal field. So not so much for us physicians, but many nurses. For example, in my hospital, we have a large obstetrics department, which is now closed down. So many of the obstetrics nurses are now working on the medicine wards or in the ICU, treating these patients. And so they're dealing with situations that they're not used to in terms of the work, but in terms of also just the talking with patients, talking with the families. It's outside everybody's comfort zone. And so that too has been a challenge. And there's also the fact that patients' families are not able to visit them. So as people are going through these struggles, they're not able to have the visits from their families, and the families are calling the physicians every day for updates. It's hard to keep them updated as frequently as they would like, but then also to address these, to inform them that their loved ones are declining. It's very heavy for the family members. At my hospital, we've started a program to try to get iPads available for every patient so that they can at least have some video contact with their family members. So that's, when possible, I think that can make a big difference for patients as well.
Thank you. Yeah, that's, wow, that's a lot is going on. And so we appreciate your experience and sharing that with us. At this point, I'd like to hand it over to my colleague, Monica, and we're going to open it up for questions.
Great, thank you so much. And thank you to both of you for for presenting and giving us both of your experiences in this. I think it's really, it resonates a lot with everyone on the call. I'm going to help just moderate the Q&A portion of this session. These questions are directed at both of you, so please feel free, either one of you, to jump in. We have some questions we received from pre-registration and a few that have come in through the chat. Everyone on the call, participants, please send your questions through the chat if you have any for either doctor, and we will make sure to get as many answered as we can before the end of the hour. So I'm just going to start with questions, and again, as I said, it's addressed to both of you, so please feel free to jump in. Many of these are LMIC or low resource setting questions. Ventilation is done so poorly in LMIC settings. Staff don't necessarily know how to use ventilators, they ventilate late, etc. Do you have any suggestions in terms of how to either ventilate better in LMICs or alternative options to use if there aren't ventilators available?
So the difference between my practice location and Dr. Hurst's is interesting because we don't have a ventilator shortage yet. We haven't totally had our peak, but I don't think we're going to have a ventilator shortage. We're going to have a skilled provider shortage. And so from a skilled provider standpoint, that's why we're doing an aggressive education move to try to teach people who are not skilled with ventilators the basics. So the other day I was teaching an orthopedic surgeon about oxygenation and ventilation, and they struggled because it wasn't about the bones. But it's important to try to educate people who wouldn't normally be in this practice setting now from a personnel standpoint. From an equipment standpoint, which is an issue more at Dr. Hurst Hospital, that's why the algorithm, we found typically it's an oxygenation problem more than a ventilation problem, and it's really tried to delay intubation as much as possible. So the interesting thing in COVID versus ARDS is that algorithm shows that we're proning patients before they're intubated, which is really kind of what we've not done in ARDS. Patients get intubated much earlier, and then proning is way down the line, really because of a resource utilization standpoint. So I would say, with all due respect to Dr. Hurst Hospital, it's a little more like a LMIC setting where they've really aggressively avoided intubation until patients were on the non-rebreather with the 8 liters per minute nasal cannula with proning. And they were really trying, because they were running out of ventilators, they were running out of ICU beds. So that would be my response to, one, the skilled provider is early education of people who typically don't work in that space. And from an equipment standpoint is what Dr. Hurst is doing is really trying to avoid intubation until there's no resort, and proning, early proning and manual proning. You know, this isn't the fancy beds, this manual proning. And it's really something in medical practice that we haven't done much, but we found that improving that ventilation perfusion matching early on is really helped.
Great, thank you. In resource limited settings without negative pressure rooms, what do you think would be the most important measures for protecting staff and other patients from exposure?
Dr. Hurst might comment a little bit. I think what they've done is right now we're okay on our negative pressure rooms, but we will quickly run out. They have run out, and they have adapted a HEPA filtration system, and also moved where patients who are either COVID positive or presumptive under investigation in the workup into a separate type of unit in the hospital that's away from other patients who are not positive or not under investigation for COVID. And then staff are wearing full PPE the entire time. So instead of saying, okay, I'm going into a positive patient's room, I'm going to put on the PPE, they're basically having COVID units that are COVID positive or under investigation. And staff, when they enter that wing of the hospital, are in full PPE their entire shift, which is obviously going to be, you know, hot and miserable, but that way the staff are protected during their entire shift. And then adding some type of HEPA filtration to the air system at least helps, because it's not really a tenable solution to say, well, all hospitals should have enough negative pressure rooms for all positive or presumptive patients.
Yeah, the only thing I would add to that is that in my hospital, what we've been doing is when we do our rounds and on any given floor, we round on the patients in order of their COVID status. So we put, to limit the amount of PPE that we're using, we gown up in the PPE, and then we start with patients who are still patients under investigation. So if we don't have their test result yet, or if they're negative, if they're hospitalized for another reason, we start with those, because even patients who have tested negative or might be in the hospital for another reason, here we still have suspicion that they still might be COVID positive. So we round on those patients first, and then the patients under investigation, and then lastly the patients who are positive, so that we're not going from, so then we use the same set of PPE for all of those patients instead of starting with a patient who's COVID positive and then having to take off all the PPE and then say negative and then have to gown up again for a positive. So that limits the amount of PPE that we have to use on any given floor.
Thank you. Dr. Hurst, sticking with you for 1 second, are you seeing a lot of secondary infections in your patients? And if so, how do you identify it, and what antibiotics or drugs are you treating them with?
So yeah, we are seeing a lot of secondary infections in our patients. We've had many cases also where a patient comes in for seemingly a completely unrelated reason, and then during their hospital course, they develop symptoms of COVID, and we then develop suspicion. So we have a very low threshold for treating these patients with the COVID cocktail, which basically includes antibiotics. Over these last few weeks, we've been using a combination of ceftriaxone and azithromycin. Now, recently, we've been switching to just azithromycin or just doxycycline if there's more concern for QT prolongation. But this is an evolving thing, so it's been changing. But most recently, we use those two, either the combination of ceftriaxone and azithromycin, or just azithro or just doxycycline, as well as hydroxychloroquine. Although recently there seems to be new studies too, and so we're a little bit more hesitant to use that. And then we also use the apixaban, as Dr. Schlesinger was talking about earlier. And in some cases, prednisone as well, if the CRP is above 150.
Great, thank you. I'm not sure who to direct this to, but there's a question that just came in regarding respirator equipment that's not available. We kind of talked about this earlier, or insufficient numbers. Is there a way to make simple temporary respirators for patients, and are there standardized raw materials for this?
It's a tough question. We've had some engineers at Vanderbilt basically take oxygen tubing where we have an oxygen source, and then have pieces of wood, just plywood that you would get like at a home improvement store, and then have a type of basically a little mechanical spring-loaded engine, if you will, that will move the pieces of wood back and forth in a bellows type system. We haven't gotten there as far as using that. You know, we fortunately are okay on our ventilator supply. Again, that may not be the case if we continue to surge. Our cases are still going up in Tennessee. But we've started to think, we've tried to be as prepared as possible. So thinking of those type of engineering solutions, we don't know how that would work in real life, in real humans. It's basically thought of just the physics of flow of oxygen and driving force, that, okay, this could theoretically work with, you know, if you think of pressure control ventilation and you might use 13 to 18 centimeters of water pressure, that can this plywood spring-loaded contraption system deliver that force using oxygen flow? Yes, but how does that really work with the dynamic compliance of the lungs? We're not sure. So hopefully we don't have to test our homemade devices, but obviously in resource limited settings, you need to start to think about that, and how can you deliver positive pressure ventilation? And so it's coming up with simple solutions. And that's going to be more beneficial than, say, having a family member squeeze the ambu bag, which we've done when we've been short of ventilators in Kenya, because that's not reliable. You know, families cannot regulate the pressure, they tire out, fall asleep, etc.
Great, thank you. A question just came in from a lab personnel in Cambodia. Do we need a separate lab for general testing like biochemistry or hematology from the routine lab? And if not, how can we protect our lab staff?
We don't do any special isolation for our lab samples. Dr. Hurst can comment about her hospital, but since it's a respiratory transmission, not really bloodborne, to the best of our knowledge, unlike say Ebola, which was our last major issue in the U.S., where we started to be concerned about PPE and dealing with highly infectious patients. We just use normal precautions in the lab. So, normal gloves, obviously careful handling of specimens, but nothing that is abnormal as far as excessive amounts of PPE that would be different from every day or a separate lab location. Dr. Hurst, are you doing anything different at Montefiore to your knowledge?
No, to my knowledge, we're following the same, exactly what you said, just the standard PPE protocols as well.
Okay. Concerning a patient that's on a ventilator, the air coming out from expiration, from the expiration of the ventilator to the room, would that have COVID-19, I guess, on it, so to speak, at that portal? Sorry, the question's a bit hard to read.
Yeah, so we, it's a closed system, but what we've done is we've added viral, HEPA filters at both the inspiratory and the expiratory limb. So that way we want to make sure we don't introduce COVID into the ventilator. So if that patient is, let's think in good terms, extubated and does well, when we reuse that ventilator, there's not a cross-contamination concern. So we have added filters at both the inspiratory and the expiratory limbs. The other thing to note is once that patient's intubated and that closed system is set up, that circuit is not broken. So if that patient were to go to the operating room, let's say, we don't disconnect the circuit, take them down with an ambu bag and hook them to the anesthesia machine. We would bring them down with the ICU ventilator. So we make sure that the closed circuit stays closed at all times, and then we added those filters in both limbs.
Great. How do you decide who to put on high flow oxygen versus non-invasive ventilation?
Well, there's an equipment concern is obviously when you think of non-invasive ventilation, say BiPAP, we don't have an infinite number of those either. And also BiPAP is going to take some work as far as either respiratory therapy. It might change the nursing ratio because that patient's going to be need closer monitoring. Obviously, if there's concerns with if having that more aggressive positive pressure ventilation with BiPAP, if they have any gastric contents and aspiration. And then it's going to take more work from the clinician. When we have those patients on BiPAP, it's not the nurse who's making the changes of the EPAP and the IPAP settings, it's us. So that is why on the algorithm, we presented BiPAP as a much further down the line option where we were exhausting Venimask and high flow nasal cannula and non-rebreathers well before we got into BiPAP and really tried to save intubation as a last resort.
Yeah, so
Thank you.
Initially we were progressing, when a patient would fail on the high flow, we would progress to BiPAP. But now as the weeks have progressed, we're trying to transition more quickly from high flow straight to intubation. Because we've seen that as patients, when they fail on high flow, we put them on BiPAP, it just prolongs the time to intubation and they don't tend to recover and go back on the algorithm. So we see that patients do better if they just progress directly from high flow straight to intubation if we're able to do that, if there are enough ventilators at that time.
Great, thank you. Dr. Hurst, to you, what are the supplies you ended up running low on that you didn't anticipate would be in such high demand?
Well, for sure, just the basic PPE is always limited. I mean, we do have enough at this time, but just the gowns, we have a very limited amount. That's why we have to be careful about arranging our rounds and really limiting the amount that we use up. The masks as well, the N95 masks, typically we get 1 mask per day. That's a little better. A few weeks ago, we were getting only 2 per week. So that was very limited. And then, of course, it's a small site, so we have a limited number of ICU beds and ventilators. So that too is, it's a constant struggle to balance.
From
Okay.
our standpoint, we, to compare and contrast, as I said, we're fine with ventilators right now. Our PP is that we have an N95 per week. If we have a known positive patient, we'll obviously exchange it between patients. But when I'm in the operating room, I have one N95. We return it at the end of the day, and we have a sterilization system using UV light to sterilize it. And then when we intubate now in the operating room, only the anesthesia team is there. The circulating nurse and the OR team leaves the room for intubation and extubation. We wear an N95 with a surgical mask over it. We put a face shield over that, and then we put a gown over our scrubs.
Thank you. Okay, that's very interesting. Some doctors have talked about having to accept lower O2 sat levels. Have you experienced this, and how low is too low?
That's a great question. And this, I did mean to talk about, so thank you for asking. How low is too low is a great question. As an anesthesiologist, when beep turns to boop and I see the 92 to 88%, I typically want to run in and intubate. And you think about, the oxygen hemoglobin dissociation curve and where patients are going to be. So the interesting thing here is not to get hung up on the SpO2 like we normally do, but it's really mental status. And this is a departure from typical ARDS pathophysiology, where these patients tend not to be as floridly hypercarbic, which would obviously affect their mental status. So we've seen patients with saturations in the 65 to 80% range who are still mentating. And while it's tempting to intubate them, when you think about what's going to happen then is they're going to be in the ICU on ventilation. It could be prolonged ventilation, then they get trached. And who's going to watch them? Do you have an ICU bed? Do you have enough ventilators? Do you have enough respiratory therapists? We've been tolerating more hypoxemia than I've ever seen in my career. And it's really thinking much less about the pure number than it is the synthesizing the whole picture and thinking about the decision based on resources, but also mentation. So I would say how low is too low is really coming down to mentation, unless there's another deleterious reason that the hypoxemia is going to be bad based on their comorbidities, which might make your decision a little easier. But when you have these patients who come in who are otherwise healthy, we've been tolerating dramatic hypoxemia.
Great, thank you. So we're coming close to the end of the session. I want to give everyone one more minute to see if there are any other questions to come in from the chat. And if not, I would love to give Dr. Schlesinger and Dr. Hurst kind of final thoughts before we wrap up the session.
Are there any other remaining questions?
I will ask one more that came in just about mental health, which I think is really important in this. Someone is asking why psychologists or psychiatrists are not being deployed directly to the forefront to accompany patients or to work with patients because of the obvious stress, and as well as the patients and for the doctors. I don't know if you have any specific thoughts on that.
Yeah, I think that's a great question to wrap up on, and ties into kind of how I wrapped up the talk. Is I think the mental, emotional, psychological health of patients, so dissecting that first, I think this is incredibly traumatic for patients in that we don't allow visitors, so now they're in the room. And obviously with the amount of PPE that the nurses and doctors have to put on, we tend not to go in the room as much as we would normally. We're going in there only when we have to. So they're in the rooms by themselves, and we've seen increased delirium with COVID as well. And I think it's horribly tragic. It's unfair, I think, to ask nurses to go in more frequently just to attenuate the mental health concerns because they're busy. And then also we don't want to burn through the PPE that we have. But I can't imagine what it must feel like, being hypoxic, basically dying alone. Like it's a horrible thought. And it's a horrible thought. I look at that picture that Dr. Hurst submitted. I can't imagine that type of practice setting. I can't imagine looking out my hospital window and seeing a truck filled with dead bodies. And I think typically in medicine, we do very poor with our self-care and thinking about it like it's another day at the office. But this isn't another day at the office. This is a novel disease presentation. And I think we need to aggressively think about the patient's mental health and our mental health. And there's some recent work or thinking about this by a psychologist here at Vanderbilt. If you want to look up his name is James C. Jackson, and he works with us in the ICU delirium group. So if you also Google the CIBS Center, CIBS, that's the ICU delirium group here at Vanderbilt, and James Jackson is our psychologist that does a lot of post-ICU PTSD and cognitive impairment and functional disability after ICU. And he's really taking an interest now in exactly that question, is how do we address the mental health of patients and healthcare providers? And like the medical practice, as I said, this is a novel disease presentation. This is something we don't know. And I think we're focusing so much on the medical care, and this tends to get easily put aside. But this is something that I have an extreme concern about, just like whoever asked that question.
Yeah, I agree. I think it's a very important consideration in all this. And one thing that could be improved at my hospital, at least, is getting these patients access to psychiatrist or a psychologist, and maybe just having the iPads available for patients is a good avenue to take. Maybe they could be connected to someone who they could speak to, and that might have an important impact for them.
Thank you. Thank you both for that. And thank you both for your time and presentations and experience. Again, this is, what you're doing is nothing short of, really missionary work and just amazing. And thank you so much again. I will pass it over to my colleague Chase just to close out the session.
Thank you. Yeah, thank you both, Dr. Schlesinger and Dr. Hurst, for doing that. This was very informative. I think our participants got a lot out of it, so we appreciate you guys taking time. We know you're very busy, but we appreciate you being here with us to answer some questions and pass on some lessons. I'd like to thank the Vanderbilt Institute of Global Health for helping us arrange all of these sessions and bringing in these great doctors. And I'd like to thank our interpreters for allowing us to reach a wider audience than we would be without them. And then a final thank you to all of our participants for coming and listening to this series and learning and trying to be prepared to help your hospitals as well. We have a QR code on the screen right now that will link you to a WhatsApp chat group if you have any further questions, or if you want to just connect with some people who may have experienced dealing with COVID-19 in their hospitals. That's a great resource for you to have. And if you have time, I'm going to be sharing a poll right now. It's just a few questions. And so if you have the time before you leave this session, if you would just fill that out for us as well, that would be great. So thank you very much, everybody.
Thank you.
Thank you.
Thank you. Thank you. It was a wonderful session.
Bye-bye.
Bye.